Welcome, everyone. We're just going to be beginning our webinar today, Inherited Retinal Diseases and Children's Vision and Eye Health, What You Need to Know. My name is Donna Fishman. I'm the director of the National Center for Children's Vision and Eye Health at Prevent Blindness, and we're so pleased to have you all with us today. This is a brief agenda, what we'll be doing today. We'll be doing some welcome introductions, of course, of our illustrious speakers. You'll hear presentations, and then we'll have time for some questions, and then we'll share some resources.
Donna's given me 2 minutes to talk about an organization that's 115 years old, so I may leave out a couple of details. But I just wanted to welcome you to the webinar today. Thanks for being here on this important topic. A little bit about Prevent Blindness, if you happen to not know us. So we are one of the nation's oldest patient advocacy organizations. Right after the American Lung Association, we were founded in 1908, and you can see a picture there of one of our leading founders, Louisa Lee Schuyler, who is the granddaughter of Alexander Hamilton. Next. Our mission is to prevent blindness and preserve sight, envisioning a world where preventable blindness is no longer a public health issue. Next slide. And strategically, as an organization, we really drive our activities along 3 key pillars. Our first is to educate, our second is to advocate, and most importantly, our third pillar is to empower both systems as well as individuals in their own eye health and eye journey. Next. And I did leave out a couple of details, but I welcome you to our website to learn more about Prevent Blindness, preventblindness.org. But certainly want to thank our sponsor for today's webinar, Janssen, a Johnson company. We couldn't have done this without you. And thank you all for being here today. With that, I'll turn it back over to Donna Fishman, who will turn it then to Donna Montage. Thank you.
Thanks, Kara. I'm really happy today to introduce our 6 speakers. I'm going to do very modified bios today. But we're going to start off with Donna Hodge. Donna leads the retina gene therapies business in the U.S. at Johnson & Johnson. Her team's mission is to bring Johnson & Johnson's first gene therapy to market to help people living with an ultra-rare disease known as X-linked retinitis pigmentosa, which is an inherited retinal disease that causes progressive blindness. Prior to leading the U.S. retina team, a different team Donna led launched the type 2 diabetes medication in Invokana, and I'm hoping I'm pronouncing that correctly. Her career began at J&J with an internship in her home state of New Jersey. Donna received her MBA from the University of Maryland and recently obtained a new certification, Black Executive Leadership Program from McKinsey & Company. Dr. Arlene Drack is a clinician scientist specializing in pediatric ophthalmology with a subspecialty in genetic eye diseases. She directs the electrophysiology service in the Department of Ophthalmology and Visual Sciences at the University of Iowa. Previously, she chaired pediatric ophthalmology at the Children's Hospital in Denver, where she directed the pediatric ophthalmology postdoctoral fellowship programs. Dr. Drack served as co-investigator in the phase 3 human gene therapy trial for RPE65 associated Leber congenital amaurosis, which resulted in the first FDA-approved ocular gene therapy. This therapy was proof of concept that untreatable causes of childhood blindness are treatable. Her clinical practice now is focused on inherited retinal degenerations. Dr. Sherry Day is assistant professor, clinical researcher, and specialist in low vision and contact lenses at the University of Michigan, where she educates the next generation of eye doctors to provide care for patients with visual impairment. She also directs the specialty contact lens and low vision course for international ophthalmology and has trained doctors from 9 countries in the last decade. Dr. Day is the inaugural section chief of the Kellogg Eye Center's Vision Rehabilitation Service, which brings together a seamless collaboration of researchers and clinicians. Carrie Branham is a clinical associate professor and is director of ophthalmic genetic counseling, also at the University of Michigan's Kellogg Eye Center, Go Midwest. She received her master's degree in genetic counseling from the University of Michigan and has been providing genetic counseling services to patients affected with inherited retinal degenerations for over 20 years. She's involved with multiple different clinical treatment trials, and her own research focuses on understanding more about the genetic basis for disease in patients affected by inherited retinal degenerations. We have two testimonials today we're really excited about. Maria Grazia Butita is a national certified counselor, author, motivational speaker, career coach, wellness and health enthusiast, and a passionate mental health and disability advocate. She regularly educates and speaks to college students and organizations about her blindness caused by cone dystrophy, which was diagnosed when she was a teen, as well as her long-term battle with depression and anxiety. She aims to end the stigma that surrounds both mental and physical disabilities, and as a special treat, she is being joined by her mother, Francesca, today. Allison Galloway is the proud mother of two children with a rare diagnosis of LCA13, which is a childhood degenerative retinal disease. She's a certified family nurse practitioner, master's prepared in food and science, and a certified surgery assistant. She owns her own practice in Boulder, Colorado, where she specializes in hormones and functional health. She's a board member of RDH12 Fund for Sight, which brings awareness to and raises money for research for her children's disease. She has spoken extensively about inherited retinal diseases and leads a yearly fundraiser called the I Love Logan and Zoe 5K to raise money for research for the RDH12 Fund for Sight. We're so pleased to have all of our presenters here with us today. And I'm going to turn it over now to the other Donna Lynn, Donna Hodge.
Thank you, Donna Fisherman. We actually figured out both our middle names are Lynn. So hi, Donna Lynn. Hi, everyone. My name is Donna Hunt Hodge. I'm the Director of Marketing for our retina gene therapy business, as you heard from Donna, at Janssen Pharmaceuticals, which is a company of Johnson & Johnson, which serves as a proud sponsor of this webcast. At Janssen, we're harnessing our experience in pharmaceuticals combined with Johnson & Johnson's broad ophthalmology footprint to help more people with retinal diseases see a brighter future. In 2019, Janssen established an eye disease portfolio to pioneer gene therapy solutions for hard to treat rare and common eye diseases. I actually got a chance to meet one of the panelists, Allison, when she was here at our office. And I can just tell you, Logan and Zoe are just amazing people. Our research teams are working determined to deliver breakthrough treatments that meet the needs of patients affected by IRDs worldwide. Today, we are pleased to have the opportunity to partner with Prevent Blindness, an incredible organization that was founded over 110 years ago, whose mission is to educate, empower, and advocate for people living with retinal diseases in a safe site, which is truly inspiring. And that's what my team's mission is at Johnson & Johnson, is to save sight. With organizations like Prevent Blindness, patients are able to receive the support they need and understand their options for living with IRD. Also, as we continue to advance research for treating this form of vision loss, here in the US, approximately 165,000 people are affected by IRDs, yet thousands of people lack any available treatments for IRDs. So I'm very hopeful for our future. When it comes to IRDs, receiving answers isn't always straightforward. Since treatment options for IRDs are limited, genetic testing has an important role to play. Through genetic testing, patients suspected of having IRDs may be able to learn of or confirm their diagnosis, which can then open up new options for potentially enrolling in clinical trials, receiving future treatments. For example, we know that genetic testing can identify the genetic variant in up to 76% of patients with IRDs. Learning about your diagnosis can also help patients plan for their future and determine if family members should also receive genetic testing as well. I encourage patients and parents of children suspected of having an IRD to ask your provider about genetic testing. It can really open up a lot of windows and help you to find solutions. I just want to, again, thank Prevent Blindness for your dedication to making a difference for people living with retinal diseases. I'm looking forward from hearing from all of the panelists, learning about your diverse perspectives that are grounded in our shared commitment to support IRD patients and our hope for treatments in the horizon. So with that, I'm very, very excited about this webcast, and I'll pass it back over.
So I'm Arlene Drack. I'm from the University of Iowa, as you heard, and these are my financial disclosures. I have grant funding for many different types of research, and I'm also on the Knights Templar Advisory Board for their grant funding. So I'm going to talk about inherited retinal diseases, IRDs. Some people say inherited retinal degenerations or disorders. I like diseases because not all of them are degenerations. They don't all get worse over time. I'm going to talk about the symptoms in childhood, how they're diagnosed and treated, and then what school nurses and childcare providers need to know to refer patients. And I'm going to set my timer so I don't go too long. So first, let's just talk about how we see in gross terms. This is an eyeball, a schematic of an eyeball that's cut in half, and you're kind of looking inside the eye. And so the cornea is the clear sort of watch glass on the front of the eye that focuses things a little bit. There's the colored part of the eye, either blue or brown or green, that controls how much light gets in. There's a lens that focuses things. And then it all gets focused on this retina, which is an orangish vascular tissue that lines the inside of the eye, like if you can picture saran wrap lining the inside of a basketball. And on the right, this pink image is an actual human eyeball that was imaged by our pathologist, Nasreen Syed. And I like it because you can see the retina when the eye is looked at pathologically like this, the retina detaches, and you can see how very thin that little tiny tissue is. And yet that is where all vision starts. It's the most important tissue for vision. It's not the only part of vision, though. We really see with our brain. So the retina has the image formation, but then it has to send that image back through the optic nerves to the occipital portion of the brain, which is in the very back of your head. And this is a functional MRI scan that shows which part of the brain is working. And when a visual stimulus is presented, the back of the brain lights up like that. So inherited retinal diseases, the inherited part tells you that they're caused by problems in our genes, because that's how inheritance is passed on. And genes code for everything in our bodies. Humans have about 25,000 different genes, and about 250 of them have been found to be associated with inherited retinal diseases. And to be associated with a disease, it has to have a mutation in that gene. So there's not like, I have the gene for RP. Some people say, well, we all have the gene for RP. It's different genes that affect things in the retina. Having a mutation in a gene is what gives you an inherited retinal disease. So genes are made of DNA, and the way it works in our body is that DNA codes to make this other molecule called RNA, and then RNA codes to make a protein. And proteins run and build our whole bodies, including our retinas and our eyes. So what are the most common IRDs in childhood? They're all said to be rare diseases, but taken together, they are not that rare. I now only see patients with inherited disorders of the eyes. They're not all retina. Some involve other parts of the eye, but most of them are retinal. And I fill many clinics, every week. So taken together, they are not that rare, but individually they are. And the most typical ones we see in childhood are Leber congenital amaurosis, Stargardt disease, achromatopsia, retinitis pigmentosa, congenital stationary night blindness, and albinism. Now, cone dystrophy, we have a speaker later who's going to talk to us about cone dystrophy. That is also one of the relatively more common ones. And unfortunately, syndromic types of IRDs are also relatively common. Syndromic means that the vision part is only a small part of the overall condition, and it can affect many other organ systems. And so Leber congenital amaurosis sometimes has other organ systems affected, so does albinism, but the ones that we truly consider syndromic have equally significant effects on other organ systems, not just the eyes. So how are these inherited retinal degenerations inherited? That's part of their name. Well, they can be inherited in almost any way that we know of in genetics. Autosomal dominant, meaning you only have to have one abnormal copy of a gene. Autosomal recessive, meaning you have to have two abnormal copies of the same gene. X-linked, meaning it's an abnormality in a gene on the X chromosome. And because women have two X's, if only one of them has that mutated gene on it, the other X is kind of protective and the woman won't get it. But if she passes it on to a son who's XY, then the son doesn't have a second X chromosome to make up for it. And so the son will have the disorder. Mitochondrial disorders. Mitochondria are the little powerhouses of our cells we learned about in biology, and all of our mitochondria are passed on through the mother. And so these have a different inheritance pattern where it always comes from the maternal side. And both men and women can be affected, but men tend to be affected more severely. And it's important to remember that all of us carry approximately 100 mutated recessive genes. That means we have one copy of the two genes that's abnormal, but it doesn't bother us. And that comes into play when we think about family history. So on the pedigree that I'm showing here, there are two children in this family who are affected with autosomal recessive inherited eye disorders. That means each of those children got two abnormal copies of the same gene. But all the people with green dots through the generations were carriers, and none of those people had any idea that they were carrying an autosomal recessive inherited retinal disease. So it can go many generations. Maybe there was never anybody in the family who got two abnormal copies and had the disease. Many times when I tell a family that their child has an autosomal recessive disorder, they're really shocked and say, well, no one's ever had this in the family before. That's actually common. It's much more common that they say that than that they would say, oh yeah, I have a cousin who has it. So what are the signs and symptoms of IRDs in children? Well, in some of these conditions, children have trouble seeing in dim light. This can be a bit difficult to know about in kids because when they're little, they don't do a lot of things in the dark on their own. But sometimes you can tell because when you're in a dark environment, suddenly they'll cling to parents. If families go camping, they notice that children can't find the tent. Or if you go to the movies, they can't find a seat in the movie theater the same way other people do. Or it can be the opposite, seeing in bright light. They might squint all the time in room light or outdoor light and then see better when the light is dim, like in cone dystrophies, like we'll hear about from one of our speakers later. Decreased best corrected visual acuity for age is often a sign. And what that means is what your visual acuity should be is different depending on your age in childhood. So just having poor vision or not seeming to see that well isn't necessarily a cause for concern. It has to be correlated with age. And I'll talk about that more in a minute. And also having a really high glasses prescription, especially before school age. Wearing glasses is extremely common. 25% of people in the United States are nearsighted, but usually it's a pretty low degree, usually below about -6. And so if the glasses prescription is really high, or if it comes on earlier than school age, because most nearsightedness happens after school age, or if it's farsightedness, if it's a very high amount. Again, farsightedness is super common in kids, but if it's a very high amount, sometimes that's a sign that there's something else going on. And then the final thing I would say is congenital nystagmus. That is a big red flag for inherited retinal diseases in childhood. So how should kids see when they're young? Well, kids do not usually look at faces until they're about 6 weeks old. So a lot of times parents will call in, they're really worried, their 2-week-old baby is not really looking at them yet. That's normal. But at about 6 weeks, kids should really be looking at your face. And if you move your head, they should move their head or their eyes to look at your face. By 3 months old, they should be following toys or keys or things that you move in front of them. By 3 years, they should be about 20/60 on an eye chart. But they don't get to 20/20 until they're about 6 or 7 years old. And all of these are best corrected visual acuity, which means if they have any need for glasses, they're wearing those glasses and you're checking their vision with the glasses on. Now, congenital nystagmus also needs special attention. You can see in this child's eye that there's just this little kind of shaking as they move their eye around and try to look at things. That is an involuntary little movement. You can see it there too. That's called congenital nystagmus. And some people, even some eye doctors, have been taught that congenital nystagmus is usually benign. That really isn't true. If you do a workup, and we'll talk more about the workup in a minute, but if you do a workup, you can usually find a cause. Only about 10% of kids have what's called motor nystagmus, where the only issue is that their eyes have this little movement. About 90% of kids will have some underlying eye issue that needs to be addressed. So how do we work that up? How do we diagnose these kids? Well, we have these different tests, the electroretinogram, visually evoked potential, optical coherence tomography, and then molecular genetic testing that we'll hear about separately. I'll go through these quickly, but I'll just say that many kids and parents are afraid of these tests, especially the electroretinogram. And on my website, draclab.org, you can find pictures of kids smiling through their electroretinogram, showing that it's not that bad. We also give kids prizes. We tell them about the prizes and we make sure that we give them because they'll remember if you don't. And then that gives us these different waveforms. And so this is a normal control where in the dark, they have one bump. In the dark with a very bright light, they have kind of two spikes here. And then with a flickering light, they have this flickering pattern. And we can diagnose often in the clinic, even before genetic testing, what a person has. So for example, with congenital stationary night blindness, their rod response in the dark is not recordable, and they have lost the B wave here, but their cone response with the flickering light is normal. In achromatopsia or cone dystrophy, it's the opposite. In the dark, their ERG waveforms are normal, and in the light, they're non-recordable. And with Leber congenital amaurosis, they're non-recordable everywhere. So we can tell a lot from this ERG. The VEP tells us how much signal is getting to the brain, and again, that can sort out whether it's an optic nerve problem or a retina problem. The OCT shows us the layers of the retina. The normal retina, even though it's like the thickness of one ply of tissue paper, has all these different layers with this little indentation in the middle. And we can tell if that indentation is not there or the layers are not right on this OCT. So to show you just a couple of cases, here's a child who had crossed eyes since birth. They had surgery for it. They thought she was seeing normally. But then they started to notice that maybe she wasn't seeing as well in the dark. So she was referred to my practice. And on an ERG, it was non-recordable. So when it's non-recordable, it tells you it's going to be some kind of Leber congenital amaurosis. And genetic testing showed she had 2 mutations in this gene RPE65. So that's not obviously what we would hope to find, except that this is the one condition that we actually have a treatment for. And I'm going to talk about that in a few minutes. In typical RPE65 Leber congenital amaurosis, kids do have vision when they're young. It's not normal, but they have vision. And these gray circles show you their visual field. But as they get older, that visual field gets smaller, and they can even lose all or almost all of their vision later in life. So it's really important that we develop treatments for these. And that's what Donna Hodge was talking about with these companies who are trying to bring treatments to these IRDs. So how do we then manage and treat pediatric IRDs? Well, low vision resources are really important. We're going to hear more about that from Dr. Day. School accommodations are really important. That's part of what low vision specialists do. And we do now have some gene replacement therapies. We have one that's FDA approved, and then we have clinical trials trying to develop more. So I was an investigator in the RPE65 phase 3 gene therapy trial that was Children's Hospital of Philadelphia and the University of Iowa. And we recruited patients 3 years old to 42 years old. And one of my patients was the first 3-year-old. She was 4 years old when she got treated. And it was a subretinal injection of this gene therapy vector. And this was a phenomenal study because on the left, you can see one of our patients who she was treated when she was older than 10, which we didn't know if that would really be successful. On the left, you can see how she was trying to navigate with her feet through this obstacle course before treatment. And on the right, you can see a year after treatment that she's following the arrows on the floor. She can see all the obstacles. I mean, it just really changed her life and her ability to navigate. And we've now found that these results are durable out to 5 years, and we're going to follow patients for 15 years. So this was just a phenomenal success. And we hope that we will have gene therapy for many other conditions. There's a website called www.clinicaltrials.gov where you can find all of the ongoing clinical trials, and it's very good to consult that website. But to be able to use it, you need to know what gene is causing your IRD. So that's why genetic testing is so important. Here's another case of a child who came in with decreased hearing since birth. congenital nystagmus and decreased best corrected visual acuity. And these little iris transillumination defects were here and variable pigment in the iris. And the fovea had foveal hypoplasia. This is that OCT I showed you on the retina. So once we got an OCT, it was clear that this maldevelopment of the fovea was the cause. And genetic testing was able to show that there was a mutation in the MITF gene, which neither of his parents had. So this is a spontaneous new mutation. So again, not having a family history, unfortunately, doesn't protect you from these things. Another case is a little girl who was referred in because she was 5 years old and she was found to have an minus 11.75 diopter myopia or nearsightedness. And everything seemed fine. She saw fine with her glasses. It wasn't perfectly 20/20, but she was close. But then her younger sister had a similar degree of myopia, and that just isn't normal. So we did an electroretinogram, and in the red, you see the ERG. Both sisters look the same. In the black, you see a normal ERG. And in the dark, they had a non-recordable ERG. And when you do a brighter flash in the dark, this B wave doesn't get above the baseline as it should. And yet the cone or light adapted ERGs are normal or close to normal. And so this is 2 mutations in the TRPM1 gene, which causes congenital stationary night blindness. And each of their parents carry 1 mutation of this, but neither of their parents have any signs or symptoms of this, which is very typical of these autosomal recessive disorders. So when to refer? When children have trouble seeing in dim light, when they have trouble seeing in bright light, if their best corrected vision, even after wearing glasses, is not normal for their age, if they have a really high prescription, like higher than -6 of myopia in preschool, if they have congenital nystagmus, and I'll throw another one in there. If they have any family history of genetic eye disease, it never hurts to have a complete eye exam and see whether that child may have something that runs in the family, but it doesn't have to be in the family. So thank you. It's my honor to be invited here today, and I'll be happy to take questions in the question session. Thank you.
Hi, everyone. Again, it's just a pleasure to be here. So I just want to thank Prevent Blindness for inviting myself and my mom. We're really excited. Again, my name is Maria Grazia Batista, and I'm really happy to share my journey with cone dystrophy from a patient's perspective. And sitting beside me is my mother, Francesca Batista, who will also share her experience, as well as offer tips and advice that we learned along the way about blindness. We know that blindness doesn't just affect the individual, but it affects our loved ones and our family members. So I have about 5 minutes. So I'm going to jump right into my story. So my story is this. I was born and raised in Sicily, and I was your typical healthy baby, came home, nothing was wrong with me. But it wasn't until I reached specific milestones, such as walking, talking, and going to school, that both my teachers and parents realized that something was different about me. I wasn't keeping up with all the other children. I was falling everywhere. And at that time, it appeared that I was just being clumsy. But again, it became more worrisome when things like reading and writing were extremely difficult for me. Now, at that point, teachers just thought I was mentally challenged and that I was slow. But thankfully, my parents were very persistent in wanting to advocate, and we really wanted to find out what was wrong with me. I was jumping from one doctor's office to the next, and we never had answers. But finally, many years later, I remember receiving my first diagnosis of Leber's optic neuropathy. That was around the age of 11 or 12 years. That was unfortunately the not correct diagnosis. Testing and blood work confirmed that I did not have this eye condition. And so, the fact that, we were getting closer to our diagnosis or to finding an answer really was motivating us to keep pushing. And finally, at around the age of 14, I received a correct diagnosis, and testing did confirm that I had cone dystrophy. And I was actually diagnosed at the Wills Eye Hospital in Philadelphia. So just real quick, I won't spend a lot of time, but in case somebody doesn't understand cone dystrophy, know how it affects me personally. Again, I think it's important to note that everyone might have a slightly different experience. I have low vision, so I have about 2200. I experience day blindness. I have nystagmus, which is that shaking of the eye that was already discussed. And I have photophobia, which essentially what it means is I have extreme sensitivity to light. And that is why I wear my sunglasses a lot, actually. So just going to spend a moment to really talk to you a little bit about my feelings around the diagnosis. So after, again, here I am, a teenager, I received this diagnosis and I'm looking in the future and I think to myself, I'm not going to have a great future. So I was very in denial. I was pretty upset, but there was this constant need, I think, for both myself and my family to, I think we wanted to fix this problem. And so I went on a couple of years going to high school, really ignoring the problem. And I think we were sort of chasing for cures at that point. But thankfully, there was a shift in my life. At the age of 21, I moved to New Jersey with my parents. And we ended up going back to that ophthalmologist who had diagnosed me with cone dystrophy. And so my mother at that point asked a really important question. And that was, well, now what? What do we do with this diagnosis if we can't fix it? What's our future going to look like? Now, I should say that I did mention that I was born in Sicily and raised there. But when it came to differences in disability, there was a lot of stigma surrounding it. And so teachers didn't really believe I could be successful, and I wasn't provided the tools I needed to be successful. So I really was caught up in that idea that being legally blind meant that I would never be successful and achieve anything in life. But thankfully, that ophthalmologist used the word commission for the blind. And then thanks to my mother's support and help, we were able to get in touch with the Commission for the Blind. And again, that was life-changing for me. I started to learn how to utilize assistive technology. I used the white cane for the very first time in my life. And, eventually I started going to college, became a speaker. I started to share my experience with cone dystrophy, became an author of my book as well, of my memoir, where I talk not only about cone dystrophy and my blindness and my journey in Italy, but also my anxiety and depression. Again, being told my whole life that I wasn't going to achieve anything really, I think, took a toll on my mental health as well. But eventually I went on to get my master's in counseling, clinical mental health counseling, became a certified counselor, and now I'm working full-time as a career coach at a university in New Jersey, which is Monmouth University. And I have a wonderful team who embraces my differences and really does support me. So see the time, I'm running out of time. So I'm just going to pass it on to Mom. But again, I'm happy to take some questions later on. But if you want to learn a little bit more about my journey, my story, please do visit my website, and that is embracingyourdifferences.com. And I'll also be sure to link that on the chat as well.
Hi, everyone. My name is Francesca, and I'm the proud mom of Maria Grazia. As a parent, it really hurt me to see my daughter struggle, and especially since she hadn't received her diagnosis. I want to talk about the things that were helpful to my family and I. After receiving the first diagnosis of cone dystrophy, I felt we weren't giving any sense of directions I wish a specialist would have referred us to some kind of resources, because I was so discouraged. I remember going out of there and being scared, and I didn't know, what this was going to lead our lives to. After a while, he explained to us what the cone dystrophy was, and it helped me understand, the process that she was going to go through. And then it helped me understand how I could help support my daughter as well. 90% of individuals who are blind or visually impaired have some unusable vision. We learned of the Commission for the Blind, which was a great resource for us. It helped, it gave us the different technology that was available to her, an additional resource that have allowed her to gain independence and the confidence. I've learned to be an advocate. I'm not afraid to speak up and educate others, because it's like, most importantly, you know what, just trust your mother's instinct. Stay hopeful, because you're not alone out there. I feel like there's so many parents out there that are going through what we went through. And you know what? I'm so proud of her, because she's successful now. She's leading her life and couldn't be more proud. So if you have any questions as a parent, but we're doing our best we can to always support her. Thank you.
Thank you so much for inviting me to talk today at the webinar. I'm very excited to talk to you about genetic testing for patients with inherited retinal diseases. And I really hope to share, my understanding is that the audience is made up a lot of educators, school nurses. I hope that one of the main points that I'll get across today is kind of the importance of genetic testing for the students and families that you work with. So just as a means of disclosure, I am a consultant for Janssen. I receive research support from them. And to move on to the actual presentation, when I think about the kind of overall patient visiting a clinic for patients with inherited retinal diseases, this is kind of very much what Dr. Drock had said. The patients will come in, they'll go through a series of tests that will help to assess the vision, assess what's going on with them, including taking family history information. Based on that, we'll get a possible clinical diagnosis, and then genetic testing generally becomes the next step in making the genetic diagnosis that then allows for accurate genetic counseling, talking to the patients and families about treatments or potential treatments, perhaps sometimes giving some additional information about prognosis, and providing that support that's ever so important to these patients and families. So you don't just need to listen to me and Dr. Drock to say that, okay, genetic testing is important for these patients. There have been a couple of recommendations that have come out from the American Academy of Ophthalmology, just kind of stating that yes, genetic testing is very important to kind of confirm the diagnosis and optimize management in patients with inherited retinal diseases. There is also an American Academy of Ophthalmology task force statement on genetic testing that came out a couple of years ago that recommends that genetic testing be offered to patients who have any diagnosis that is suggestive of a Mendelian disorder, so one of these genetic eye diseases, including inherited retinal diseases, and that the ophthalmologist should consider providing care and as needed refer on for genetic testing and genetic counseling. So when we think about genetic testing, really it's quite simple actually. And the goal being to see if we can identify which of those 25,000 different genes that Dr. Drock mentioned is responsible for the genetic condition in these patients. So if you look at it, really, you get a sample from the patient. It used to always be done on blood. Now a lot of that testing is a saliva sample, cheek swab, much better, easier for these children. From that sample, you extract the DNA out of the sample, and then sequencing is done on the lab to look for kind of any misspellings within the gene that would make the gene not work in the proper way, which could potentially be the cause of disease in the patients. So why do we do the genetic testing? Why do we even think this is important? I'm going to tell you the reasons, and then I'm going to give you a couple of case examples to illustrate why it is that we think genetic testing is important in these patients. One of them is just to kind of confirm the diagnosis. So sometimes it's very clear based on all of the different tests that are done, based on the retinal findings, exactly what the diagnosis is, but not always. And sometimes depending on what the exact gene is, sometimes there can be other health problems. It is a minority of those patients, but as Dr. Drock mentioned, you can have syndromic inherited retinal diseases where there can be other non-ocular health problems. It's important to diagnose and manage those. Sometimes identifying the genetic basis for disease can help us understand prognosis a little bit better, kind of what to expect in the future. It can help us to understand the risk to other members of the family, so confirming the pattern of inheritance and allowing for screening in other members of the family who may be at risk for the same condition, and then also to determine eligibility for treatments or clinical trials. Any clinical trials that are targeted at a specific genetic cause of disease, you're going to have genetic testing in order to know if that is the genetic cause of disease in you, in order to be eligible for any of those treatment trials. So as I mentioned, a couple of examples, and I know this group is kind of focused more on the pediatric population, but in this particular case, we're starting with an older patient. This was a 73-year-old man who was referred to our clinic for a possible diagnosis of inherited retinal dystrophy. And that kind of diagnosis comes to us all the time. He actually had a history of poor vision dating back to when he was very young, so dating back to first grade, but no one had really made a specific diagnosis in him. He had previously been seen at our eye center as a younger adult. He had poor central vision, visual acuity at that time was 2400, 2100, and his diagnosis at that time was made as an unspecified macular degeneration. Coming to see us at 73, his vision had decreased 2800 to 2250. He had a central blind spot on visual field testing and foveal atrophy, so atrophy in the very center of his retina on exam. Getting family history information was actually a big clue within this family. What we were seeing within the family is males who were affected and connected to other affected males through females. And that type of inheritance pattern is what we would normally see in an X-linked condition. The other males in the family, though, there wasn't really a diagnosis given in them either. He had a grandson who was born with a retinal detachment, is what they said, and a brother who was similarly affected to our patient, and that brother's grandson who had decreased vision as well. So we did genetic testing, and this patient was actually found to have mutation in a gene called RS1, which is consistent with a diagnosis of X-linked retinoschisis. That is an X-linked condition. And so actually that is one that there is a clinical trial that is going on for. And the other thing that knowing that genetic diagnosis allowed in this family is his daughter was pregnant with another son. And we did do genetic testing on him and actually found that he did not have this particular genetic variant, so not at risk for this condition. So within this family, through genetic testing, we could confirm the diagnosis, set up for the potential in some members of the family for clinical treatment trials, and then also understand if screening needed to be done on the grandsons to see if they were going to develop the condition, in which case his newest grandson was not. So my next example of why we need to do genetic testing, an 8-year-old female referred for decreased vision of unknown etiology. Her medical history, she was also affected with type 1 diabetes. Within the family, no other members of the family were affected. Her parents noted that she had decreased vision starting a couple of years ago around the age of 6. And from this and the previous records, we were able to see that she had a relatively rapid decrease in vision around the age of 6, 2050, by the age of 7, 2200, and it had even decreased more by the time that she came to see us. The electroretinogram, the ERG test, she had non-recordable rod cells and severely reduced cone cells. So we tested her on a 351 retinal dystrophy gene panel. And unfortunately, she was identified to have 2 pathogenic variants in a gene called CLN3, which causes a condition called Batten's disease. And this is a condition that, unfortunately, it is a syndromic condition. It's not limited just to the eyes. It's actually a neurodegenerative condition in which you see vision loss starting around the ages of 4 to 10. And then a little bit later, behavioral cognitive dysfunction that can be overlapping somewhat with the vision loss. And then in the teen years, progressive motor decline and seizures, and unfortunately, reduced life expectancy in the 2nd or 3rd decade. So that wasn't a good outcome, but we were able to kind of identify what exactly was going on, what do we need to be looking out for, and help the family to kind of understand what's coming down the road. My third and final example of different reasons for why it is that we do genetic testing. This is a 20-year-old male referred for a possible retinal dystrophy. Decreased vision noted within the last year. Visual acuity was 20/40. No other family members with vision loss, and nothing on his medical history that was non-contributory. He also had genetic testing on this large retinal dystrophy gene panel, which identified pathogenic, which is disease-causing variants in a gene called RPGR. This also is an X-linked condition, and you would typically see multiple members of the family affected, generally male members of the family. But in his case, he was the only one. And that's something that we sometimes do see. It's possible that there were other members of the family that maybe were other females that were carrying this disease-causing gene, but just not showing any signs of the condition. And so this kind of third example is lending to the importance of clarifying the inheritance of disease and thinking about diseases that maybe we wouldn't necessarily thought of just based on the family history of alone. In particular, those gene mutations in some of those X-linked genes. Our group, we had done a study looking at isolated males and showed that 15% of those isolated males actually had a mutation in one of the X-linked RP genes, RPGR or RP2. There have been other studies that have been looking at isolated cases in which they thought maybe they had recessive cause of disease, but it actually was a dominant or an X-linked. And an additional study where they thought that it could have been a dominant type of disease, but actually they were found to have mutation in an X-linked gene. So the summary of kind of all those cases is doing that genetic testing really helps us to clarify more about the diagnosis, setting up for the treatment trials, and also helping us to understand what the inheritance is to provide the family information on that. So that was the why we do genetic testing. The how we do genetic testing. Genetic testing is typically, it is ordered through a healthcare professional. So in other words, a patient cannot just order that testing on their own. It needs to come through a healthcare professional. This may be a geneticist and or a genetic counselor who are ordering this. There are some ophthalmologists who are familiar, like Dr. Drock, who are familiar with working with these cases, who may order that testing. Other ophthalmologists may not be quite as familiar. They may not have that level of expertise to kind of provide that information to patients about how to order the testing and how to interpret those test results. So when a healthcare professional decides to order the testing, there's a couple of different considerations that they have. And one of them is test selection. As I was showing in those case examples that are mine, we generally will order kind of this broad-based panel testing where we test for multiple genes. And kind of the examples that I gave is kind of the part of the reason. Even though we have what we think, maybe we think it's going to be a recessive disease, but then it actually ends up being an X-linked gene, or we weren't exactly sure if it's a syndromic or non-syndromic condition, that kind of supports the doing this broad-based panel. But there are some other examples where it may be appropriate to just do a single gene or even a single mutation if someone else in the family has already had testing. The healthcare professional can also talk about cost considerations with patients. There was a time when all genetic testing had to go through insurance or a patient would have to pay. And genetic testing can actually be fairly expensive. There are some labs now which do have financial assistance program, kind of a sliding scale, or they can offer some assistance to patients if their insurance will not cover the cost of the testing with a reduced self-pay price. We're also fortunate in the area of inherited retinal diseases that we do have sponsored testing that's available. There are a couple of organizations, the Foundation Fighting Blindness is one of them, and another program through a lab called Invitae Genetics, in which they can offer patients genetic testing at no cost, therefore making it very accessible to a much broader audience than what we would have 10 to 15 years ago. With the genetic testing, there's generally an informed consent document that goes along with that. That is kind of important to help the patient understand exactly what the testing is, how they're going about doing that testing. And then the samples collected, sent to the lab, those genetic testing results will go back to the healthcare provider who will then disclose the test results. And that's why we do think it is important that the provider who's ordering the testing, be it the geneticist, genetic counselor, or the ophthalmologist who's ordering the testing, has the kind of the knowledge, skills, and ability to interpret those test results. It's not always straightforward or easy to understand. So just to end with a little bit about genetic counseling. So what is it? I'm a genetic counselor. I work specifically with patients with inherited retinal diseases. Just to kind of summarize the statement, genetic counselors, we work as a part of a healthcare team to help patients understand and adapt to genetic information, which can be challenging. It can definitely bring up emotions if you're dealing with feelings of guilt from passing a disease within a family, that sort of thing. And so genetic counselors can have kind of a role in multiple parts of this pattern that we shared about. They can help gathering that family history information, so understanding what's going on with the patient, help with the test choice, help arranging the insurance, logistical aspects of it, and then kind of all aspects at the end. So providing that genetic counseling, interpreting the test results, letting patients know about test results, and then providing support as needed for those patients. So just to conclude here, the key takeaway points that I hope you've kind of gotten away from what I've said today is that genetic testing really is an important part of clinical care for patients and families with IRDs. Genetic counselors can be partners in that care for the genetic testing process. And we are fortunate that if someone thinks, I can't have any genetic testing done, my insurance won't pay, there are options for sponsored testing that do make it accessible to a greater number of people.
I'm fortunate to work in a multi-center practice where, you know, we have people like Carrie, we have people like Dr. Drack, and occupational therapists who specialize in low vision, and myself. So I like to talk about, kind of address what Maria and her mom was talking about, you know, kind of getting the resources to patients early on in this process. So let me just forward here. Okay, so I talked about how we wanted to kind of get the resources out there. It's important to connect with the schools. It's important for the doctors to write letters advocating for the children in the schools and the devices they need to use, and other rehabilitative resources as well. And most of our referrals come from other health professionals, educational professionals as well, and government agencies such as the Bureau of Services that Maria talked about, and other nonprofit organizations. So during what we do as the low vision optometrist is when a child comes in, we do a full low vision examination, and that includes a very thorough history taking. So we want to know what the child is, we understand to a certain degree what is needed in the schools. So as they progress in in school, their needs, their functionally, the vision needs will change. So we do see children on an annual basis at least, and of course, more frequently when their vision changes. So we want to connect with the child. We want them to kind of play with them. We want to have that conversation with them. Of course, we do have many conversations with parents. We do, and if the teachers, you know, in the school district that work with the children who are visually impaired, they want to come along, we welcome that as well. That's added information for us too. So what do we do during the low vision exam? Most of our patients are referred to us either from pediatric ophthalmologists, pediatric optometrists, or pediatricians directly. If they have not had a full ocular exam, dilated exam, we do want that. We do that, but otherwise, most of them are referred in, and we skip that. During the exam, we do a thorough examination as to what the prescription is. So Dr. Drack talked about a really high prescription. That does matter in how we prescribe our devices. So we want to make sure the child has the best corrected vision, either through contacts or glasses. We want to test their side vision, the contrast, because if they have low contrast, this comes into play in how we refer, you know, for orientation mobility, and assistive devices too. And we will, through our evaluation, we will be able to calculate how much magnification, what type of devices are going to be able to achieve their functional goals. For example, most kids need to be able to read a book. Now, first grader book, the print size is different than, say, an eighth grader's print size. So we target the exam, we customize our time together with the child, depending on the functional needs. Some kids want to play sports. Some of my high schoolers, they're in football teams and there's a lot of glare. So we want to customize that exam for them. So this is just an example of the contrast that I talked about. On the left side is a normal vision. On the right side is somebody with very poor contrast and they are also legally blind at 2200. So we have these discussions with the parents as to the results that we find. So after the exam, we do talk about referrals and how to co-manage and communication with schools. And I will go through this in one of the cases that I will present. There's a lot of state resources and national resources as well. We are currently also trying to get a psychotherapist on board on our team because we think that is absolutely very important. And as Maria talked about, and I'm glad she is one of the few counselors that understand vision impairment. We don't have many here. Okay, this is the case of a child who actually was referred to us, and she actually came to our department when she was 2 years old. And she had genetic testing, and we found that she has the mutation for RPE65. And if you see the top, this is a side vision testing that goes out to 180 degrees. This is when she was about 5 years old, and she was actually a really good child where she actually can sit through this exam. And so we got a really good visual field for her. But you'll see from 2014 to 2017, just in 3 years, her visual field started to constrict. And this is where Dr. Drake showed the video about, how they have mobility issues, right? So this child at the time, Luxturna was just on the brink of being approved, but not yet. And so at the time, the decision was to have the child undergo a trial gene therapy with Mira, and the left eye came 3 years later. So she had the gene therapy, and then she came to Low Vision Clinic when she was about 11 years old. So this is her, a brief synopsis of her exam at 11 years old with us. So Dr. Jack talked about the high prescription, and here she is. She's a -11, really nearsighted, but she's also already legally blind. So 2200 or worse with the best correction, like glasses or contacts. If you're 2200 or worse, that is one way to be for legal blindness. Her near vision is 1.6, and all that means is that she can only read large print. Her contrast was really low. Normal is about 2. And at the time, she actually lived in a really good school district where she was already connected with TCVI, which is a teacher consultant for visually impaired. She already started orientation mobility training with a white cane. And she was already learning Braille because we knew early on that her vision was going to get worse. So that visit, we just prescribed her new glasses and an 8x telescope so that she can achieve 20/60 vision through that telescope. We also recommended a portable CCTV because around 11 years old is when she's probably transitioning to middle school and they might be changing classrooms. So she needed a video magnifier that could go with her. So the top photo is just a stock photo, but it's a portable CCTV versus the bottom one is more of what I call the desktop version, and it just stays in a room. 2 years later, we see her, and again, her vision doesn't improve. Even though the right eye has had that gene therapy, the visual acuity hasn't improved yet. And so this time she wanted to try the Orcam My Eye, which is it looks like this device up here with the glasses. And basically this device, and I'll talk about it a little bit more later, it actually reads to you. Okay, so audibly she can hear it. And so we requested this for the school. So when I kind of mentioned that the needs in elementary school, middle school, and high school are different for the child. And so when you're in a populated center, like a big city, we have many resources, right? And so for example, in the state of Michigan, we have teacher consultants for the visually impaired who are in the school districts. Where we are in Ann Arbor, The county has about 9. Ann Arbor City has about 9 TCVIs right now. And they can help with implementing the devices that we recommend, or any accommodation, orientation, mobility training, and teach Braille if needed. But the most important thing for the TCVIs is to have an individual education plan that is written by the child's doctors. And low vision optometrists, for like myself, we write very specific details, and I'll go over this with this patient. So what is an IEP? It is a legally required document for any child who has special education needs. So it could be physical, it could be vision, and usually they meet every 6 months. So again, I mentioned that a lot of these people, they can come to the meeting or present letters and requests as to what type of accommodations would be helpful for this child. For her in primary school or middle school, some of the accommodation would be like a large print keyboard, a dome magnifier for the elementary child, large print materials, books, a bold line paper, and markers like a Sharpie or something. And depending on the inherited retinal disease that they have, some filters can be worn to reduce glare, especially when they're working on a computer screens a lot nowadays. We recommend orientation mobility to start early as well. So this would look different when this patient comes into, when she's a college student, for example, we might say, so these are some of the things I would write in the IEP very specifically. For example, Times Roman 36 font or larger, bold, if things are going to be printed for the students. White letters on black background versus, black letters on a white paper. So these are very specific things I do incorporate in the IEP when I write to the schools. And I also request extra time for projects and homework. Now, as this child is looking into college in the future, Maria, mentioned the Commission for the Blind, and in the state of Michigan, we're called Bureau of Services for Blind Persons. And the mission is employment and independence for the customer or the patient, they call them. For example, in Michigan, we have a youth low vision service that works with patients who are 20/70 or worse. You don't have to be legally blind at this age to tap into this resource. There is a transition pre-employment service. And so if this child, a 14-year-old wants to work part-time, for example, this is where the youth low vision service would be really helpful. They have a college assessment and preparation course. So the summer before they enter college, they will live on a college campus and learn to navigate and live in a dorm and prepare themselves for college. And also in Kalamazoo, one of the cities in Michigan, the Bureau of Services has a blind training center. It's a live-in facility where someone learns everything, how to cook, how to do woodwork, any hobbies, assistive technology, everything. And they can live in there up to 6 weeks, and they could customize their time there. And again, I reemphasize that the IEP is incredibly important, so that all these agencies, all these interprofessionals know how to customize the time with this child. So let's go back to this patient. Remember the right eye? She had the gene therapy in 2017, and in 2021 on the right side, this is her visual field now. So it was reduced. It's about, and I do the horizontal about 75 degrees roughly, and then 4 years later, she now has about 105 degrees horizontal visual field, which is definitely improvement. Obviously, there's a little bit of error in there, test taking error as well, but it shows that this would be helpful in her mobility with an increased peripheral vision. So when we talk about peripheral vision, I think about driving. As this child, she's 13, I think she's 15 now, but now she's looking at, can she drive? That's a very common question I get from parents and children, of course. So the point of this slide isn't to tell you what Michigan offer, but the point is to say, you need to know your state's driving laws or ask your doctor. This should also be posted on your Secretary of State or Department of Motor Vehicles website. But in the state of Michigan, for example, the best corrected vision has to be 20/50 or better and a peripheral vision of 110 degrees. If you don't have one or the other, you cannot get an unrestricted driver's license. And there's a lot of other stipulations. For example, Michigan has a stipulation about, is it a progressive disease, right? If it's progressive, they're a little stricter. If it's non-progressive, it's pretty stable. Then they give you a little extra wiggle room. And now 38 of the 50 states allow a bioptic telescope for driving. It's a telescope mounted permanently in glasses so that you can drive. Now, in the state of Michigan, not only do you have to get that customized and made, but you have to go through a certified driver's rehabilitation school. And these schools are certified by the states, the Secretary of State, the DMV for the state. Just to go back to this side, this is one of the most difficult questions I do have with patients, adults and children alike, especially the adults who can no longer drive. And it's important that we legally tell them what they can or cannot do for their safety and others as well. Okay, I mentioned the OrCam for this patient. The OrCam My Eye, it's a point and read. So for example, you would have a piece of paper, and I don't know if you could see, but there's a piece of paper, and if you're wearing the OrCam, the camera's right here on the frame, it can see, you point at it, and it'll just start to capture the page, it'll read to you line by line. Now, the newer ones are, the newest model actually has intelligent reading. So for example, if you have a newspaper article, it can read like the headline, you can say, read the headlines, or it can do facial recognition for you, orientation as well. So if you're in a room that you're not familiar with, it could scan the room and say, hey, there's a table to your left, or a chair to your right, so that as you navigate the room, you don't actually bump into these large obstacles. Now, why not the eSight for her? eSight is a head-mounted device, mainly for central vision loss, and it works best between 20/60 and 2800 vision. Beyond that, we find that it's not very helpful. eSight also has a near function too. So it autofocuses. But for this patient, it wouldn't be the best option, only because her peripheral vision is starting to constrict. And eSight actually projects outside of your central vision for it to work the best. There's a lot of apps nowadays for patients with vision impairment, and especially with these kids who are so tech savvy, much more than I am. They can download some of these apps. For example, and I'm not going to go over all of them, and this is definitely not comprehensive, but IRA, for example, will connect you to a live person, and just you can say, I need to find the restroom in this building, and so they can see where you are. They can navigate for you. They, for example, like the airport, Detroit airport, it's free to use in there. They have the blueprint of the airport, and they know where you are, and they can navigate, help you, walk you through it. It is a paid service. However, IRA has given everybody 5 minutes free. So a lot of times we'll say, call them up, work with them for 5 minutes, hang up, and you could call again. But certain places like the airport, it's free to use, so you can stay on as long as you want. And there's certain pharmacies, for example, I think it's Walgreens, it's also free to use.
Dr. Day, I just want to let you know your time is about up. So we
Okay.
will be sending, people will see this on the recording also, these,
Perfect.
and we can list them. Thanks so much.
Yeah, we're almost done. And the script talk, I want to emphasize the script talk. It reads, it tells you about your prescription. So it's really important that you take the right medication, the right amount. And certain pharmacies have that. And lastly, just a few other resources around the nation. There is actually such a thing called a guide dog in addition to, guide horses in addition to guide dogs. And I actually saw one in a lobby years ago, and it just looks like a big dog, but it's actually a pony, a small dog. So And then Prevent Blindness and Foundation Fighting Blindness, those are all resources for you. There's a lot of support groups out there as well for IRDs or just low vision support groups in general. So the take home points really is that early intervention is crucial for the child, but also for the family. The youngest child I saw was 3 months old, and it was not so much I could do anything for the child at this point at 3 months old, but it was really talking to the mom and just guiding her as to what to expect and what's to come and all the resources that she has, and to be the best advocate for her child. Thank you.
Yes, I have a very in-depth slide, as you will see. It's just my babies on the screen and all the activities they're doing. Logan is my oldest, he's 12 years old, and Zoe is my youngest, she is 10. And I'm just going to dive into my diagnosis story because unfortunately, or my kid's diagnosis, because unfortunately it's not an uncommon one. It's one that, talking to many parents, it's a pretty common situation. So when my son was 3 years old, I noticed that he couldn't see on the playground, didn't have depth perception. He had the nystagmus, the bouncing eye. He couldn't see in the dark. And we were just very frustrated. We had gone to an ophthalmologist every year since he was 1 to try to figure out what was going on with him. And every time we went, they would just say, oh, he's too young. We can't test him. We can't figure out what's going on. Just come back in a year. So at 3 years old, I brought him into the same ophthalmologist's office. My daughter Zoe at that time was still breastfeeding. So I had a little baby and I had Logan, and the doctor went outside the room, grabbed a whole bunch of other doctors, and they all came in and took turns looking at my son's eyes, his retina, all kind of doing the, oh, I concur. Yeah, so I see it too. And I'm just sitting there like, what are you guys all seeing here? And they all left. The doctor then proceeded to write down 2 words on a piece of paper, handed it to me and said, this is what we think your son has. There's really nothing you can do about it. We do recommend you get an ERG. She didn't explain what that was to me. And you need to do that at Children's Hospital. So I wrote that phone number down too. So that's all I got. And then, so we left, and like any good person these days, when you get a diagnosis, what do? You turn to Google, Dr. Google. So we went to Dr. Google, and I'm sitting in the car with 2 little kids in the back seat, and I look up the diagnosis she wrote on the paper, which said retinitis pigmentosa. Any parent that is diagnosed or their child is diagnosed with the disease just knows that feeling where your heart just falls to the ground. Just realizing that my child had just potentially been diagnosed with the disease that will cause blindness, and just being lost because there was, quote unquote, nothing I could do. We did go to the Children's Hospital here in Colorado, where we signed my son up for an ERG, which was a very, I know that technically it's not supposed to be a scary experience, but we had never met the surgeon or doctor doing the procedure. We knew nothing about it except for what I was able to research. My son went under anesthesia. He got the ERG, and this young doctor, like I want to say it was like 28 years old, just came out to us, sat down with us and said, his ERG is flatlined. It's been proven he has a retinal degenerative disease. And that's all I can tell you. You need to get some genetic counseling to figure out what it is. And then he just left. And we called his office the next day and said, where do we go from here? He then had the nurse tell us that there was really nothing we could do about it. So to just kind of deal with it. I wish I could say, like I said earlier, that my situation was a rare time. But it was pretty common with all of the other parents that I talked to when their child was diagnosed. As far as the genetic testing goes, I am a huge proponent for it. But at the time when my child got diagnosed, we were put on a 1-year-long wait list to get genetic testing. This was 10 years ago. So it wasn't as known or as common back then. So instead of sitting around and waiting and being the impatient person I am, I reached out to all my provider friends and found the University of Iowa, where Dr. Drack is, and we saw one of her partners. and got our diagnosis of LCA 13, which is RDH12 mutation. So what my kids have is an autosomal recessive disease, meaning my husband and I do not show any signs of it. We have no one in our family with any history of it. And unfortunately, both of my kids got it, which is pretty rare. My daughter was fine when she was younger, so we actually thought she was okay. But at 3 years old, we were sitting at a restaurant and I looked at her eye and all of a sudden it started bouncing. And I knew right away that she also had it. So we were blessed with the Carver lab. We sent in labs to them and figured out what she had. I will say the bright part of the diagnosis, we were just lost. We didn't know what to do and where to go. I'm going to give Dr. Drack's office like big, whoop whoops here, because we called and got a nurse, or I called and got a nurse on the phone who is still one of my favorite people on the face of the earth. And the first thing she said to me was, "Mom, it's going to be okay. We're going to figure this out." And so I think as any healthcare provider, if you have a patient that is diagnosed, just know that you're not just diagnosing the patient, that you should be treating the parent as well. It is a huge shock. I mean, the stories I would make up in my head about my kids never going to college, never being able to do anything because they were going to be blind, and just not knowing anything about this disease. It was a really hard pill to swallow, and then to have both of your kids diagnosed with it. So I praise those nurses and docs out there that say, "You know what, Mom, we got this. You can rely on us. We're going to take care of you and your child." So I know a lot of the providers talking today because, like I said, we went to University of Iowa, we went to University of Pennsylvania, we've been to the Kellogg Eye Center. We're very familiar with a lot of these amazing women on this panel, and we're blessed to have them in this field. So the point is, I want to kind of talk about, as an experience as a mom and a child, if you're a teacher or a provider, kind of just give you some points. I could speak for hours on this topic, but so Logan is 12 and he's a Braille reader. So he's pure Braille. Miraculously, he can play video games really well and see those. So it's like a selective vision he has. But how I explain my kid's disease, you have to kind of dumb it down for people, is that you take a piece of cardboard, you put it up in front of their eyes and you punch a whole bunch of holes in it. So my kids can see through those holes really well with no glasses or correction. But as time goes on, there's just become less and less holes. And that's how we kind of describe what my kids' vision is. Zoe is 10 and she still can read large print, but she is learning Braille because we know this is a recessive disorder. In talking to many parents and professionals, they don't bother teaching Braille to the kids yet. But what I have learned is kids are sponges. Teach them young, get them learning the Braille, get them comfortable with the Braille. And then when the time comes, they know they have that tool. Other things are, as a provider, just know that a rare disease is like being on an island. You're kind of by yourself and you don't know where to go. You search the internet, you search everything, you ask people. So be a good resource for your patients or for your kids if you're a teacher or a school nurse. The internet can be bad and it can be good. We were blessed in that when we finally got our diagnosis for my children, we found a whole group of parents that had the same diagnosis for their kids. And that's how we developed the RDH12 Fund for Sight, where we try to raise money to get a genetic cure. We are totally jealous of everyone with RP65 that had Luxturna, and we dream of the day that we can get our kids a genetic cure. But we also realize that it may not happen. So it's really important to set your kids up for the future, just in case they don't find a cure. So the big things I will say are, don't limit your children. The biggest thing adults that were blind told me and guided me is, don't treat them any different than any other kids. Push them, give them chores, give them things to do. Don't let them cop out of things because they need to learn this stuff. My kids go to a public school, and I've many people ask, why don't they go to a school for the blind? And we have great ones here in Colorado. But my opinion is kind of, the world is sighted and my kids need to grow up in it. So if I have the ability to keep them in a sighted school and have them learn the techniques they need to learn, then they're going to be more successful. We have amazing opportunities that I have found for my kids. If you look at these pictures, my son ran cross country. My husband and I would tether to him. My kids played hockey, a sport I never thought they'd play. And it's like a coffee can with ball bearings in it. And so they can hear the puck. And that was through USABA, the United States Association of Blind Athletes. We have a Colorado Center of the Blind that does cooking lessons, that takes them skiing. We're actually going rock climbing this Saturday with them. The National Federation of the Blind does a bell camp every year, which is amazing. And it's all people with low vision, and they learn how to do like riding the bus, getting on transport, navigating with their phones. It's just an amazing, and it's free, an amazing resource. But I will say our biggest resource was my public school. We are blessed to have the school we have. We have TVIs, or the vision teachers, as been talked about before, and they are our family. They have been everything to us. Without them, my kids would struggle. My son is in middle school. We were terrified for middle school, but he uses a Braille note touch, which has made the world of difference for him as far as keeping up with other kids. It's a great piece of electronic. My daughter has used the CCTV. I mean, there's so many things out there. I think the biggest thing to say is some kids are going to resist them. Some kids are not, and not everything works great for the kids. My son has also used the OrCam that Dr. Day was talking about, and he kind of likes it and kind of doesn't like it. The other thing is, not every vision issue is the same. So treat the child per their vision issue, because, you know, people think that blindness is all or none. You're completely blind or you're not, and that's not the truth. So you kind of have to tailor it to the kid's disease. Other things are, for example, my vision teachers had my children stand up in front of their classes in like 2nd or 3rd grade and explain their disease. And what that did was empower my children to explain what their disease is, but also to have other kids understand. I mean, even have them do it to adults. The more they explain it, the more they advocate for themselves, and the more you encourage that, the better off they're going to be. Other things are therapy, not just for the child, but for the parent. I mean, your world changes when your kids get diagnosed, and the guilt you feel is overwhelming. So to have therapy for yourself.
I'm so sorry to cut you off. We're just wrap up in about 30 seconds because we're almost out of time. Thank you.
Gotcha. 1 minute. So getting therapy for your child and for yourself is really critical, because as a parent, if you're struggling, your kids are going to see that, and they're going to think that there's something wrong with them because of this disease. So you need to be able to be a healthy parent for your healthy child. The last thing I'm going to say is, as far as IEPs, they are terrible, horrible things as a parent. It's something you don't look forward to. I actually got my TVIs a coffee mug that says pre-IEP, and then a wine glass that says post-IEP, because we all need a glass of wine after an IEP. But having a good vision teacher, having good people around you, having a therapist in your IEP, encouraging the child to participate. My son is in middle school now, participates in the IEPs, and he loves it. It empowers him. And the other little piece of knowledge I've had is advocate for everything in your IEP. I mean, everything. We couldn't get a line on the top of our staircase in our elementary school so that my kids could see where the stairs started. And we fought and fought for months for it. And we put it in the IEP. I mean, you just put everything in there because it gives you a power to fight for what your kids need. So that's my story. Thank you guys for having me.
As all of you who are here today can see, this is a team effort, right? From having from going to the ophthalmologist and getting information and getting the examination and having the genetic testing and learning and seeing a low vision optometrist and hearing from our 2 people giving testimonials, to Maria Grazia and Francesca, and then from Allison, all about how to adapt and how to thrive. And I think that this has been such an uplifting, informative webinar. I cannot thank everyone enough. And again, I want to reach out and thank Janssen, Johnson & Johnson, Donna Hodge for being here. It's been great to have this support. I'm just sharing this one quick resource. We're going to send our slides with the other resources because I know we're just about out of time, but just wanted to show that we have in English and Spanish a fact sheet on inherited retinal diseases. And I think Anne is going to put the link for that in the chat. We also have at Prevent Blindness, our Living Well with Low Vision website. You can see there's a section for patients, caregivers, and healthcare professionals. So much information on here. I hope you'll visit that as well. So again, I want to thank everybody for their participation today, especially our presenters, but all of you who listened in today. Thank you and have a great day.